Hi, good afternoon. My name is Joffre Olaya. I'm a pediatric neurosurgeon here at Children's Hospital of Orange County, here locally. And this is Dr. Jennifer Cheng. She's a neurosurgeon at University of Kansas Health Systems. So today we're going to talk about phase 2 evaluations. That is, we'll discuss SEGs, grid, strips, and a little bit more. So I don't have any disclosures. So as we all know, epilepsy is a devastating condition. Fortunately, most patients are able to have their seizures controlled with medications, but unfortunately about a third or more become intractable, meaning that they're not able to control their seizures with medications alone. And so when patients get to that point, then we should start thinking about potential surgical treatment options as well. I know there have been a lot of talks throughout the day, and there'll be several more talks talking about the preoperative workup and then also about the surgical treatment options. Today we're going to focus on the invasive monitoring part of the process, but we'll briefly talk about some of the pre-op and post-op issues as well. So when somebody is determined to be in epilepsy surgery, when we're thinking about epilepsy surgery, we do an extensive workup, including an EEG or VTM, long-term EEG. We get a brain MRI to look at the anatomy of the brain to see if there's a specific focus where the seizures are coming from. We get other studies like a PET scan, which looks at the glucose or sugar metabolism of the brain. And so many times for patients that have epilepsy, there's less sugar uptake in those particular areas, and that can help guide our treatment options. There are other studies as well, such as the MEG, which is a great talk earlier today, and SPECT, that can also be utilized to help localize the seizure onset zone or where the seizures are coming from. In addition, we do psychiatric testing to get a baseline neuropsych function, and then it's also something that we can continue to monitor if somebody has surgery to see how patients do. Obviously, there's always a concern that surgery may cause problems, but then we also know that many times neurocognitive function can actually improve after epilepsy surgery because the epilepsy focus is removed, and so the brain is able to function better. So once we have all of that data, we present it in a conference, and it's discussed by many team members, including neurosurgeon, epileptologists, neuroradiologists, neuropsychologists, and it's a whole big team effort. And once we discuss all the information, review everything, then as a team, we come up with a plan. And as part of that plan, potentially we may need to do further investigation to again better elucidate where the seizures are truly coming from. So when we determine that someone's an epilepsy surgery candidate, every center has a different process, but essentially we go through some sort of algorithm to decide what the next best step will be. So again, in the simplest form, if the seizures are localized to a specific area of the brain on the EEG, we have imaging studies that show that the seizures are coming from that area. Then potentially we could go straight to a surgery to resect that area. But most of the time, it's not that simple. Most of the time, the studies aren't concordant; they don't match up, or sometimes the imaging studies don't show anything. An MRI could be normal, a PET scan could be normal, but we still know that the seizures are coming from a specific area. So in those cases, then sometimes we need to find more information from deep within the brain. And so that's when we start thinking about what's called SEEG, or stereotactic depth electrode placement, or subdural grid and strip electrode placement. So the depth electrodes is to find a focus that's deep within the brain. The grid and strips is to localize the focus that's on the surface of the brain. And so as we look through the algorithm here, we can see that if if the seizures are localized to a specific area on the EEG, the MRI is concordant, we can potentially go all the way down to the bottom here and essentially go straight to a resection or potentially a laser ablation. However, if the seizures are focal, but they're not quite lateralized yet, then potentially someone could benefit from having SEG electrodes placed, so depth electrodes placed on both sides of the brain to then figure out which side the seizures are coming from. Or if the focus is very deep, then SEG electrodes would help localize that better as well. Now, if the seizures are, if we've kind of followed this algorithm here, sorry, I can't see it very well on this side. If we follow the algorithm here, and the seizure onset zone is close to important cognitive areas of important cognitive function, so the language area or the motor area, then sometimes we need further information to not only find where the seizures are coming from, but also be able to map out where the motor and language areas are. So if we were to treat that area, we don't cause any significant neurologic problems or deficits. And so again, this is kind of the general algorithm that we follow to then decide whether somebody, if we need to get further information, whether somebody's a better candidate for SEG or grid placement. So SEG electrodes look something like this. You can see there's contacts all along the electrode here. And now these can be placed different ways. I specifically use the ROSA robot, but there's other robotic devices. There are other systems that can be used to implant these electrodes. And so it doesn't really matter which system you use, but essentially you just need something that's going to be reliable and be able to place the electrodes in very precise locations. So we do a lot of work before the surgery to map out and plan exactly where those electrodes are going to go, and particularly cautious with blood vessels. So we do specific imaging studies so we can look at the blood vessels as best as possible, so that as we plan the trajectory for these electrodes that go from outside all the way deep in, that we don't hit any blood vessels and potentially cause any injury or any bleeding. The setup for SEG is fairly simple. We essentially just have, with the robot, once we make a plan, the arm will go to the entry point, and then we make a little incision in the scalp, make a little opening in the bone. So you can see on the prior slide there was a drill. So we make a little opening in the bone, it's about 2 millimeters in diameter, and then we place these bolts that we secure to the skull, and that's what holds the wire in place. And then there's a little cap that then secures the wire. So this is, you can see the bolts there. There's the driver that helped to secure the bolt to the skull. We have a stylet that we use to pass down to the trajectory to kind of create a space for the wire to go down. And then we measure it using this ruler here at the bottom. And then once the electrodes are in place, then we get imaging studies to confirm that the electrodes are where we plan them to be. And so this is a skull X-ray, basically just showing how with SEGs we can sample extensive areas of the brain on both sides. So in this particular patient, we see electrodes that are in the frontal area and the temporal area bilaterally, and then we're able to capture seizures and then better lateralize and potentially localize where those seizures are coming from. This is what it looks like in a patient. So again, you see the bolts are secured to the skull, and then you see the little caps that are holding the wires in place. One of the big questions that I get asked for these procedures is, how much hair are you going to have to clip for the placement of these electrodes? And it really depends. Every center is a little bit different. Some centers will always shave all the hair just to help minimize the risk of infection. Other centers won't shave any hair at all. I'm kind of in between. I'll clip the hair around the area where we're placing the electrodes. But there's no right or wrong way to do it. Everybody just has a different protocol. So I just want to give an example of a patient that we placed SEG electrodes in. This was an 18-year-old young woman who was having daily seizures, and she had the extensive epilepsy surgery workup, and the seizures were likely localized to the right temporal lobe. But there was still some of the information wasn't concordant, it wasn't matching up, so we needed to make sure that there wasn't any seizure activity coming from the other side as well. And so that's why we placed bilateral electrodes on both temporal lobes, and then we captured seizures to see where the seizures were coming from. Fortunately, all the seizures were found to be in the right temporal lobe. So then we took out the electrodes, and then we were able to do a temporal lobectomy and remove the area. So this is an MRI here, actually showing that there, as part of the workup, the preoperative workup, we did see that there were some changes here in the temporal lobe, right about there. And so we already had a target, where we were going to place the electrodes. And then when we did the monitoring, then that confirmed that the seizures were truly coming from there, and we weren't seeing any seizures coming from the contralateral side, from the opposite side. So then we were safely able to then perform a temporal lobectomy. So we resected that area where the seizures were coming from. And now it's been over 5 years now. The patient's graduated from college, has been seizure-free off medications for all that time. Now, interestingly, Dr. Cheng will present some other cases a little bit later, but looking back, this is a case that we did years and years ago. But since then, we started doing laser ablation, so ablating the specific area where the seizures are coming from, and so that's another alternative. And so if you can find that the seizures are coming from a very focal, deep area, then you can use a laser to then burn that tissue, so that you don't have to do an opening and do a full temporal lobectomy. So that's definitely another option as well. So as you can see with SEEG, they're small incisions, so it's minimally invasive, which then leads to less pain, less blood loss. It's very well tolerated. Patients have the electrodes placed. They get admitted onto the ICU, and really within a day or so, they don't even look like they had any surgery. All you see is their heads are wrapped up. You see the wires coming up from the top, just like they would have just for a typical EEG stay. Now, one of the challenges with SEEG electrode is because you're only sampling small areas of the cortical area, so the surface of the brain, mapping language and motor areas can be a little bit more challenging. But that being said, there are centers that have been very successful mapping language areas, for example, using SEEG electrodes. So this is a study from New York that looked at 15 adult patients. 9 of those patients had SEEG electrodes placed. 5 of them had grids, and then 1 of them had both SEEG and grids placed. And so when we do language and motor mapping, we provide a direct electrical stimulation to each contact in the areas where we're concerned that there's eloquent function, so where there's language or motor function. And so what we're looking at here is representation of the brain. And so the top brain here is the patients. These are all the patients that were studied. All of their information was put on one image here. And so this is all of the patients that had the grids and strips, so the 5 patients. And then the green dots represent where they stimulated the area, but it didn't cause any language deficits during the stimulation. The red dots represent the area where, when it was stimulated, patients had loss of language function. So then that correlates with the language area. And so then we know when we go to treat the patient that we want to avoid that area so we don't cause any damage. Now on the image below, you can see the SEEG representation. Again, you can see all the dots are all the contacts that were stimulated. And again, you can see the red dots and the green dots. So the green is safe, the red you want to stay away from. And so you can see that out of all these patients that had SEEG electrodes placed, 6 of the patients ended up having a resective surgery, and none of them had any language deficits afterwards. So the authors then suggested that doing language mapping using SEEG can provide sufficient information to be able to determine whether language is in the area of the planned resection, and patients can still have a resective surgery without causing any neurologic deficit or language problem. But I would point out, if you compare the 2 images, the image on the bottom here and the image on the top, you can see how on the top you see lots more dots, both red and green, and so you can see that you're definitely getting a lot more coverage of the brain. And so you can see how many red points you see there at the top, and on the bottom you don't see as many. So you definitely get better coverage using the grids and strips, and you're better able to delineate where that language area is. So although you can do some language mapping based on the study, it's still not as thorough as a grid and strip placement. So if you're truly concerned about language areas, then some centers may still lean towards grids and strips for that. So in patients that we do need to place grids and strips, that essentially entails performing a craniotomy. So you make an incision in the scalp. We open up the skin, we elevate the bone, we open up the dura, which is a covering over the brain, and then we place electrodes directly over the surface of the brain. So here's a cartoon showing the electrodes directly on the brain, and so each number represents a contact, electrical contact, and that's where we're recording the electrical activity from seizures. The M and the S represent where they mapped out the motor and sensory regions. Now this is what the electrodes look like. There's lots of different sizes and shapes and configurations of these electrodes, and they're all used for different things. So this is a standard 8x8 grid, so when we're mapping a large area of the cortex, particularly over the language and motor area, that we can get a lot of coverage with that one grid. But you can see there's some other smaller ones. There's some strips that sometimes we'll place underneath the temporal lobe. This one here actually has contacts on both sides, so that one can actually be placed interhemispherically, so in between the two hemispheres, and you can actually record electrical activity from both sides. So if you're concerned that potentially you're still having lateralized, then that grid can help with that as well. And then you can see there's an example of a high density grid here. So whereas standard grids have contacts approximately 1 centimeter apart, in this higher density grid they're about 3 millimeters apart. So if you need to get more resolution, then you can have the electrodes closer together. It just creates a lot more data, so it can be a little bit more challenging to interpret, but it can be very helpful, and I'll show an example of a case where we use that. And so again, you can see the numbers on top of the electrodes there, and then these are what the contacts look like on the undersurface of the grids and strips. So this is an example of a case where we did a craniotomy for grid and strip electrode placement. This was a 15-year-old young woman with multiple daily seizures, and based on her surgical workup, the seizures were likely arising from cortical dysplasia lesion that was abutting or next to the motor and language areas. So she had been having seizures for about a year. She was having 1 to 3 seizures per day. During her seizures, her eyes and head would deviate to the right for about 10 seconds, and occasionally the seizure would generalize. She had tried 2 medications and still continued to have seizures, so at that point she was presented for epilepsy at Epilepsy Surgery Conference. So we can see as part of our workup we got a brain MRI. And on the MRI, we could see here, if you compare one side to the other, you see this area here that's a little bit thicker, and so that there's already an area of suspicion where potentially there's a focal cortical dysplasia. You can see a little bright spot in that same region there with a little tail that we can often see with the cortical dysplasias. This is a different image here, again called a flare sequence, showing changes in that same region, and then a T2 image showing the same thing. Now, because the lesion appeared to be close to the language and motor areas, we did a functional MRI. So this is a study where it's an MRI, patients are asked to do certain tasks during the MRI, and then as they do those tasks, specific areas of the brain can light up. So this was a language paradigm, so there's different things that they ask patients to do. Sometimes you repeat something, you read something, and then as you do that, then specific areas light up. So you can see the bright areas that you see here represent language areas here. And if you remember the image from before, that's close to where the lesion was. This is looking at motor function, and again, motor function was found to be similarly in that same area. And so we talked about different options, including SEG and grid placement to better localize the lesion, because we knew that we had an image to target. SEG placement was an option, because if we just targeted that specific region and we found that that's where the seizures were coming from, potentially we could then ablate or burn that tissue. So that was one option. But because it was so close to the language and motor areas, the family decided that they wanted to have a grid placed so that we can truly see where that language and motor area was. So this is an X-ray that was done afterwards, showing the grids and strips around the area of interest. And in this particular case, we did use that higher density grid that I mentioned earlier, where the contacts were about 3 millimeters apart, so we get a little bit better resolution. Now this is, and once we placed the grids, the patient got admitted to the ICU. Once she recovered for a little bit, then and we captured seizures, then the epilepsy team, the epileptologist in the team, then did language and motor mapping. So as I mentioned before, that entails providing direct electrical stimulation to each contact. And based on the anatomy, we have a general idea where the language areas are, but we want to make sure we're precise. So they sequentially go through each contact, stimulate the area, and then see, again, as I mentioned before, whether language stops or whether there's movement, and then that area would correspond to language or motor function. And so we can see this is a configuration of the different grids that we had. You can see a little bit better here. So there's a picture actually on the brain. So you can see the grids and strips in place. And so you can see that the yellow areas represent where the seizures were coming from. The blue area, the light blue area, shows where the hand motor function is. So, and then the darker blue area shows where face motor function is. And typically those areas are very close to each other. And then the purple area showed where language area was. So you could see all of those things were right next to each other. So based on that information, then we were able to expose the area where the lesion was and protect the area where the language and motor function was. And then we did a resection and took out that tissue where the seizures were coming from. And then we actually found a lesion in that area. And so now it's been about 4 years or so since her seizure. She's been seizure-free and is a very successful college student now. So it can be very, very beneficial to place grids and strips, particularly in these areas where there's language and motor function involved.
Just this? Okay. Hi, I'm Cheng again. I'm at Kansas University Medical Center, and I just have a couple additional cases that are just illustrative of some of the same things that Dr. Olaya was talking about. These are an adult patient. So this is a 30-something-year-old man, BA, who had polymicrogyria. So this is a picture of his MRI of his brain, and there's actually abnormalities that he was born with here. They're developmental abnormalities that were quite extensive around this area called the Sylvian fissure. So this is an example of someone getting, again, stereo EEG. So again, the wires that are implanted into the brain to try to more precisely define the seizure focus. Because we can see this large area that has abnormality, but we can't just remove this huge area. That would not be compatible with him having good functioning. And so we wanted to be more specific, and so that we did stereo EEG. And then you can see on MRI, and you can see on a skull x-ray what it looked like after he did the SEEG. And so as part of this patient's treatment, we actually found kind of a widespread epilepsy network. So the seizures were not necessarily starting from one small location where you could just pinpoint that location and take that part out. The seizures would start kind of in a widespread fashion and kind of involve quickly large portions of this abnormality. So we ended up doing a procedure that we call radiofrequency ablation to treat him, and this has been successful for stopping this patient's generalized seizures. So he still does have some focal seizures, but he's no longer as debilitated as he was before the radiofrequency ablation. So I'm going to just talk a little bit about that. So radiofrequency ablation is a medical technique that has been in use for some time for treatment of other things, such as, you see here, trigeminal neuralgia, like other types of things that are not epilepsy. But it's something that we can specifically use when someone is undergoing a stereo EEG study. So when they have those wires that are in the brain, and again, the purpose of those wires is just to determine where the seizures are coming from, sometimes we can do this treatment during the hospitalization, and we can electrically stimulate at a specific contact, and we can put enough stimulation in there to actually cause an ablation of the brain. So a very, very small ablation of a small area of the brain. And this is something that is, so first of all I should mention, is done in an off-label fashion, okay? It is not expected to be curative. So very few people would end up being seizure-free just from doing this, because we're only ablating a very small portion of the brain. But sometimes it can be informative. It can teach us if the seizures change or decrease, which happens sometimes, and that can be a good predictor to say that we were right, that the seizures are coming from that area. Now, let's say the seizures get better, but then they recur, then that person may need more surgery in that area to provide a bigger resection, either by laser or by an open resection. So as another example, we have this patient who is a young lady who has tuberous sclerosis. So she was born with something where in her brain, she's prone to forming tubers. So tubers are lesions that some can turn into cancer, but most often they don't. They just kind of just sit there. But those parts of the brain could cause seizures. And she had multiple tubers throughout her brain. And many people who have tuberous sclerosis are like that, where there's, you have a person having seizures, but there's multiple lesions everywhere. So you're trying to figure out, well, which one of these lesions is really responsible for causing the seizures. So she had stereo EEG. Most of these lesions were targeted when we had reason to suspect that her seizures could have come from there. And we found that these two areas on this MRI in the posterior cingulate, so this is kind of deep in the brain, where there were tumors, were causing her seizures. So we did this radiofrequency ablation, and for this patient, it ended up decreasing her seizures significantly for roughly for 2 years. And then after that, after which seizures became more troublesome again, and she has recently undergone a different procedure, neuromodulation, to treat her epilepsy. So a little bit more about this. This scan shows, this MRI scan shows what happens about roughly 1 day after radiofrequency ablation. So you can see here that this is what the electrodes look like, and that there's some edema. So when you heat the brain, you cause an ablation, there's a normal reaction. The brain kind of swells a little bit in that area, but over time that swelling goes down. So over time, if you were to look at an MRI of the same patient, probably 6 months to a year later, you would actually see very small, probably 1 centimeter or less lesions where this radiofrequency ablation was. It's a really nice technique that can be done at the bedside with the patient awake, interacting with you. It does not hurt, does not cause pain, but this is a way to ensure the safety of the procedure. Like, as we're doing the ablation, we're talking to them and making sure that they're functioning normally. Okay, so that was that. I also have a case to show similar to Dr. Olaya about the grids. So in our case, in this patient, we ended up doing the stereo EEG first. So we, at the time, had more of a widespread hypothesis about where his seizures could come from. So we felt we needed to do the stereo EEG to figure out that. But these areas, here we can see in kind of red and orangish yellow, those were the depth electrodes that seemed to be where the seizures were coming from. And again, just like in the case of his patient, these were near speech areas. So this is why we thought we need to do a grid to better define that. And I would say that in the general field of surgical epilepsy, grids have been the way things have been going, or grids and strips, for the longest time. And stereo EEG is now kind of rising as a more often used procedure because again, it is so minimally invasive and there's a lot of advantages, which Dr. Olaya is going to go over in a little bit. But still, there's still these situations where we may say, hey, we need more fine tuning, we need more definition, so let's do a grid. So in this case, the patient had one of those large 8 by 8 centimeter grids placed with 3 additional strips that were placed under the patient's temporal lobe. And this, again, goes step by step through the same type of algorithm that he described, where first the patient is in the epilepsy monitoring unit. We're gathering what data we can. So first we do interictals. So interictals is where we're having a lot of sharp waves. So that brain is irritated. It's probably where the seizures are coming from. And so the neurologist gathered the data about these red spots, which is where we had the most sharp wave activity. Then when the patient had seizures, then we have a different map. We say, in this case, it's these 2 red spots. Those were the areas that lit up exactly when the seizure started. And then you combine that with mapping. So similar to what he said, we can do cortical mapping and really well defined. Again, that's done with a patient awake. You're at the bedside, typically with a neurologist, possibly with a neuropsychologist, and we're providing a little bit of stimulation, one by one, onto each contact, and having the patient interact with you. They're talking to you. You see at what point they have an effect, a side effect, such as suddenly stopping speaking, speech arrest, or other things like hesitancy, motor things like hand or tongue movement. So this becomes a way to get a very, very good picture with good resolution of what the specific functions of the brain tissue are. So he underwent 2 days of speech mapping, and that gave us this nice picture here that you can see on your right side, where we can see the area, the red rectangles here, were the areas where he had speech arrest. So those are the most important areas for his speech his language. And then you can see that it overlaps exactly with the highest areas where the seizures were coming from in these yellow circles. The purple dot here was, just to reference, that was the most active stereo EEG electrode from his prior mapping study. So unlike Dr. Olaya's case, where he could say, okay, well, we have speech close by, but separate from where the seizures are coming from. In this case, it was exactly overlapping. So we could not recommend a resection to this person without causing serious harm to his language functions. So he ended up going with what's called responsive neurostimulation. So it's a type of neuromodulation. We think that you guys are going to have another talk later this afternoon discussing these strategies for neuromodulation, which are often used when we cannot safely remove part of the brain that the seizures are coming from. So with the responsive neurostimulation strategy, this patient's seizures are significantly better. He does not experience any generalized seizures. He has very brief focal seizures, and he's still on some medications, but not on as many as he was before. And he, for example, is driving because he doesn't have any seizures that impair his awareness anymore. Okay, so that's my couple examples, and then I'm going to have Dr. Olaya come back up.
Thank you. So we're going to have to wrap it up pretty soon.
We have 2 minutes.
Okay, perfect. Yep, so we can talk about thalamic SEG if we have a few minutes after the question, so I'm going to skip over that for now. But I did want to just go over kind of a brief summary of a study that compared SEG electrode placement and grids and strips in pediatric patient population. And again, just highlighting the benefits of the two different strategies. So again, they compared patients with they did a meta-analysis, so they looked at lots of different papers, 14 papers for subdural grids, 9 papers for SEEG, and they looked at hundreds and hundreds of patients. And so what they found was that in this patient population, patients that had subdural grids tended to have a higher rate of CSF leaks, cerebrospinal fluid leaks, bleeding, higher rate of infection, and the seizure freedom after surgery was about 50%. Whereas with patients with SEEG electrode placement for their invasive monitoring, they had very minimal CSF leaks, much lower rate of hemorrhage, no infections, and also had a good seizure freedom outcome compared to grids and strips. So to wrap it up, again, safety and efficacy of epilepsy surgery is well established, and you've heard a lot of talks throughout the day. You'll continue to hear more talks describing that. Invasive electrophysiological monitoring of SEEG and subdural grids can help guide the surgical treatment options. And again, both strategies have risk and benefits. And again, we need to tailor the modality to the patient. Both curative and palliative approaches may be used to improve overall patient outcome. And when we look at success from surgery, we don't necessarily only want to look at seizure count, because again, we're looking at seizure freedom on that last slide. But even with patients that are not seizure free, after they have epilepsy surgery, they tend to have a better cognitive function, better quality of life. And so there are other things that we need to look at aside from just seizure freedom. We all know that epilepsy surgery is better the earlier you do it. We know that outcomes are better. And we know that surgery has risks, but the risk of not having a surgery may be greater. With that, I'll open it up to questions. Thank you.
Our microphone is out, so if you have a question, just use your outside voice. Any questions? Everyone's tired from lunch.
If we have a couple minutes, I can talk a little bit about the thalamic SEG.
Sure, that'd be great.
Yeah. So one thing I want to talk about is kind of newer strategies that have been coming out over the last few years. So as we talked about, we use SEG electrodes to try to localize or lateralize where the seizures are coming from, with the goal of potentially resecting or ablating, burning that tissue. However, many studies have recently come out looking at the utility of using SEG electrodes to localize not only where to resect or ablate, but where we can target our neuromodulation devices, so our DBS, deep brain stimulation, or RNS, responsive neurostimulation, and particularly looking at the thalamus. So we know that seizures don't necessarily, although they may start in one area, they can spread very quickly throughout the brain. And so we want to be able to find the nodes that are involved. And sometimes even if we can't find the specific onset zone, if we can affect the pathway, we can get a good seizure control. So again, just to briefly go over the anatomy here. We can see the outside of the brain here. This is what's called a coronal view, so this is looking head on. And just to point out where the thalamus is, it's a deep structure here, kind of in the center of the brain. And the thalamus itself has this kind of ovoid shape. And the thalamus, as you can see, has multiple different substructures within it. And so there's been different studies throughout the years looking at different areas of the thalamus that can be stimulated to help get better seizure control. Particularly, there was a large study called the Santé trial, which was used to look at deep brain stimulation to help control epilepsy, and they targeted the anterior thalamic nucleus, so the front part of the thalamus here. There have been other studies looking at the central median nucleus, which is this middle structure over here. And then in some patients, the pulvinar, which is the posterior part of the thalamus, can also be stimulated to help get seizure control. This was one of the papers that I pointed out earlier, showing a strategy of implantation for the SEEG electrode. So when we're monitoring for seizures, they go in with the idea that the seizures are likely coming from the cortical area, so the outside part of the brain, but knowing that there is a possibility that they may not find a specific target, so they place electrodes all the way down into the thalamus, so they can also look at what the electrical activity looks like when patients have seizures in the thalamus itself. And if they couldn't find a area to resect or ablate, then the idea was to use the information in the thalamus to then target that with a depth electrode, a permanent electrode that's placed, that then is connected to a stimulator, a neurostimulator, so either a DBS or an RNS. So this just shows different strategies for targeting the outside of the brain, and then following the trajectory deep into the thalamus here. And so we're sampling along all the different contact points. And then based on that information, again, we can then place an RNS, a responsive neurostimulator, or a DBS to then, and the difference between the two is that the DBS is giving a constant signal to that area, and that can help decrease the overall seizure burden. The responsive neurostimulator is nice because it also collects data, so you can actually see what the electrical activity looks like when the patient is having a seizure, and then you can program the device to then respond to that specific electrical activity. So I'll leave it at that and open up for any additional questions.